So today's topic is going to be on femtosecond laser assisted cataract surgery, also known as FLACS. And in particular, we're going to be discussing whether or not the literature supports the marketing. So first of all, can I have a show of hands? How many are familiar with FLACS? Okay, very good. How many of you have been to a presentation on it already? Okay, so just a few. Okay. Very good. All right, so first, just a couple statements about me so you understand a little bit about me, my practice, as well as why I'm here talking about this particular conversation or topic. First of all, cataract surgery is actually one of the focuses of not only my practice but my career, and not just in terms of performing it, but also in terms of educating those about it. So for example, I wrote a book about cataract surgery that was focused specifically for patients, addressing their needs, their concerns, and helping them to choose among the numerous options that are now available. Because it's not like it used to be decades ago, as we know, where you just had a cataract, put a new lens, you were done, get some new glasses. Now we know we have a lot of different lens options, and now there's this type of surgery option available, so laser-assisted cataract surgery, and we'll talk about that. As a doctor who's in private practice, I also spend, on average, between 45 and 60 minutes with my new cataract surgery consultations. And that's because I think it's really important to actually communicate all of these very, very confusing topics to patients, and that just cannot be done in a short period of time. And finally, as adjunct assistant professor of clinical ophthalmology at USC, my primary role there is teaching residents how to communicate these things to their patients in the clinic, as well as developing the skill sets they need in the operating room. So first of all, I have no conflicts of interest, and this is important to be aware of with each presentation that you get on something that's going to cost your patients hard-earned money. This will not be your typical industry-sponsored dinner talk, which just glosses over the side effects and touts all of the benefits. I want you to have a clear understanding of what the literature states. Okay. So first of all, what is laser cataract surgery? Well, that's a misnomer. Okay. We do not perform cataract surgery with a laser. It's not been done, and it's still not. What it is, in fact, is femto laser assisted cataract surgery, also known as FLACS. The femto is short for femtosecond, and this is the same laser that's used very successfully with LASIK. Instead of using the microkeratome, you use a laser. It cuts through clear tissue, such as the cornea, very, very well and very precisely. And that particular term is one that you will be exposed to if you've not already been exposed to: precision. One of the things that the marketing pushes about the femto laser assisted cataract surgery, I'm just going to call it FLACS from now on, is that it's more precise than manual for the traditional ultrasound only phacoemulsification. And precision is a term that you have to recognize comes with a lot of assumed promises, and we're going to discuss whether or not those assumed promises are actually borne out. So first of all, can I just give an idea? When you hear the word precise when discussing cataract surgery, what are some of the things that you think that might be describing? Any ideas? Capsulorhexis, right. So precision in creating the capsulorhexis. What other things do we look for with precision? What do patients ultimately want after surgery? Better vision. Closer to 20/20, closer to 20/20 uncorrected. So if we could get something that could accurately get somebody there, that would be very desirable. So precision is being used very loosely in marketing and advertising to make us feel like we're going to get our patients closer to 2020. That's the assumed promise. So let's see whether or not that's actually the case. Other marketing terms you'll hear, safer. Okay, well, when you hear safer, what do you think? What do your patients think when they hear safer? Less side effects, less risks. Let's see whether that's the case. The other thing you're going to see, gentler. Laser is gentler than ultrasound. Okay? Again, gentler, one would think, safer, fewer risks. So let's take a look. Just briefly, for those who aren't aware, what does this laser do? Right? It makes incisions, corneal incisions, the side port incision, the main incision. You can also make arcuate incisions, so limbal relaxing incisions to correct for astigmatism. Now, traditionally we do these with metal or diamond keratomes, but they can be done with a laser now. You mentioned creation of the capsular axis. The laser can create a perfectly round capsular axis, and it is beautiful. When you watch this laser perform a capsular axis, it is perfectly round. The question is, does it matter? Now, traditionally, we perform the capsular axis with either forceps or a 10-cent vent needle cystotome. Okay. The other thing you can do is soften the cataract. Well, softening the cataract makes sense because if you can soften the cataract before using ultrasound energy, you'll use less ultrasound energy. Less ultrasound energy should protect the corneal endothelium, should result in less inflammation, faster healing, and just generally a gentler procedure. So this is where the term gentler comes from. Now, you can also soften the cataract using certain phacoemulsification techniques, such as chopping, which is a newer technique. It's a more challenging technique, but it's one that most surgeons should be capable of performing. And chopping essentially does the same thing as the laser softening. So, what does the laser do? The summary is, nothing that can't be done already, hasn't been done already. So the real question is using a laser to perform these things truly superior to the ultrasound only? And the marketing tells you that it is. And indeed, if I was to present the industry-supported marketing, it looks pretty slick. But we only have about 20 minutes today. So rather than show you all of that, which you can find very easily, and I personally don't believe it because it's industry supported, right? So, he who pays the piper chooses the song, right? Chooses the outcome of what's going to be published. I find that literature to be very questionable. So I've chosen instead to present to you the literature that you're not going to get presented at any industry-supported evening dinner show, but instead the peer-reviewed large studies that were performed by non-industry supported groups. So this is here just an expression of my disappointment as well as others' disappointments when we realized that, wow, there's really nothing that the laser does that we can't do already. It just does it in a way that sounds a lot cooler. So let's take a look here. This is Peter Barry, the late Peter Barry, who presented the preliminary results of a study performed by the European Society of Cataract and Refractive Surgery. And I'd like to thank my colleague, Dr. Stephen Saffron in New Jersey, who brought many of these studies to my attention as I was investigating whether or not this was something that I wanted to provide to my patients. So this study was not a small study. There were 16 centers in 10 European countries throughout Europe. And this involved almost 3,000 patients. So, what were the results? Unfortunately, the visual acuity, which we were hoping precision would result in better acuity, it turns out that in this study, those who had FLACS actually ended up with worse visual acuity on average than those who had phacoemulsification only. Now, it was small, but still, it was worse. And the whole point is, if we believe the marketing, that it should be better. But it was not. Gets worse. There were more postoperative complications among those who underwent FLACS than those who underwent standard phacoemulsification. Take a look at this. This requires that we spend a moment and think about it. Those who underwent FLACS were more likely to have post-op visual acuity that was worse than pre-op. Why do we submit our patients to the risk of surgery? To make their vision better. Okay. Any new technique or technology has to, at the very least, not make patients worse more often than the gold standard. So FLACS fails there. Well, let's take a closer look. And because these results are really unintuitive, right? So let's first take a look at the idea of accuracy. Again, what is being loosely referred to with the marketing term precision. One would think that if you're targeting plano refractive error, or -1/2, whatever it is you're targeting, that this more advanced technology is going to get you closer to your target. Well, indeed, that's not the case, at least not based on the preliminary results of this very, very large study. Postoperative surgical complications. I think it's important to look at the types of complications that are more common. Corneal edema, posterior capsular opacification, and uveitis, so anterior chamber reaction, cell and flare. Okay, and these are not small differences. Okay. In fact, corneal edema is 5 times more likely among those who had FLACS. Posterior capsular opacification, 6 times more likely. Now you may say, okay, that's not a big deal. We take them back to the YAG laser, good to go. But YAG laser is not without risk, especially in high myopes. 3 times the risk of anterior chamber reaction. Okay, you say, but that's just one study, albeit a very large study, almost 3,000 patients. Well, it's not the only study. There's another study that looked at almost 2,000 patients enrolled. And what this one found, and I'll read the conclusions because it's a little difficult for you to see, Femtosecond Laser Cataract Surgery did not demonstrate clinically meaningful improvement in visual outcomes over conventional phacoemulsification cataract surgery. If you look up a little bit higher, it gets even more concerning. Okay. Phacoemulsification cataract surgery cases had more letters gained compared with laser cataract surgery. Okay? So conventional actually did better. And why might that have been the case? Well, let's look again at risks and complications. Perioperative complications, laser cataract surgery and phacoemulsification only. So if you take a look at those ringed in the red, you'll see that there are some significant differences, but not just your usual, just barely less than P, or P is less than 0.05. These are really statistically significant. But more important than statistically significant, they're clinically significant, right? Ocular hypertension, cystoid macular edema. These are things that can result in loss of vision. It should be noted that these are not the first studies to show that cystoid macular edema is at increased risk in FLACS. This study is from 2014 and showed an increased risk of cystoid macular edema in cataract surgery patients who underwent FLACS. So why might this be? What could be going on during the laser portion of FLACS that results in more likely corneal edema, increased anterior chamber reaction, IOP elevation? cystoid macular edema, and posterior capsular opacification. What could be the unifying factor here? Okay, well, let's take a look at some of the studies that have actually looked at the changes that occur during and after the femto laser portion of the cataract surgery. So with corneal edema, what could be going on? Well, it turns out that the bubbles that occur, the cavitation bubbles that occur from the femtosecond laser, change the pH in the aqueous. It shifts it to a more acidic aqueous. And we know that the corneal endothelium is exceptionally sensitive to changes in pH. Anterior chamber reaction. Oops, sorry, went too far. Anterior chamber reaction. Prostaglandins have been shown to rise immediately after femtosecond laser treatment. Prostaglandins are part of the pro-inflammatory cascade. Okay, but that's not it. It's not just the prostaglandins. Okay. There are, in addition, other inflammatory mediators that have been shown to increase after the femto portion of the cataract surgery. How about posterior capsular opacification? Well, it turns out that femto is associated with a higher concentration of fibroblast growth factor as well as other pro-fibrotic factors. The conclusion from that particular paper was that femtosecond laser pretreatment in cataract surgery significantly induces altered levels of pro-fibrotic intraocular cytokines, which are involved in the development of PCO. Increased levels of these cytokines, I'm sorry about the spelling there, and growth factors in aqueous humor in the early phase after cataract surgery could induce lens epithelial cell proliferation, migration, and transdifferentiation. So this is a posited mechanism by which posterior capsular opacification could actually be more likely after femto. And it's a reasonable hypothesis. So then, where does this leave us with regard to FLACS versus traditional ultrasound-only phacoemulsification? Well, first of all, let's take a look at the benefits. I mean, the marketing benefits don't seem to have a lot of support in the literature, at least not in the non-industry supported, large-scale population studies. Okay? But you have to admit it's cool. I mean, it is a really cool technology. Anytime you have laser and you put it with anything, it just makes things cooler. Okay? And this is very much true with patients. They hear laser cataract surgery and they want it. And it is a lot of fun for the surgeon. Okay, ophthalmologists in general are kind of geeky. We like our Star Wars, and most of us have seen Logan's Run, and there's something about doing surgery with a laser that it feels cool. And I will say, having performed FLACS, it is fun. There's just something about watching that video screen. It turns surgery into a video game. And so from the surgeon's perspective, it's a lot of fun. And it does give bragging rights to the patient. Okay? Patients get to tell their friends at the golf course, at cocktail parties, that they had laser cataract surgery, right? And that really does sound impressive. Even more so when you find out that in general they have to pay extra for it, right? So it's kind of like anything that you have to pay extra for, whether it be a nice bag or you know, a really nice car, whatever it is, you get bragging rights for it. But to date, there's no strong evidence from, and this is key to recognize, independent, so non-industry supported, peer-reviewed, right? So actually, you know, published or presented in, you know, major conferences. So no strong evidence from independent peer-reviewed studies supporting an objective benefit, not just a cool-sounding marketing term benefit like precision, which basically means nothing clinically, but an objective benefit to patients of Flax over conventional phacoemulsification. But it gets worse. Flax appears to actually be associated with greater pro-inflammatory changes in the aqueous humor that can lead to increased risks of vision-threatening post-operative complications, including corneal edema, anterior chamber reaction, cystoid macular edema, posterior capsular opacification, and intraocular pressure elevation. And I've not spoken about any of the other risks that were common in the early studies of femtos, such as capsular tags and increased risk of posterior capsular rupture and things that were largely associated with learning curves of the surgeon or with improvements in technology. We've not talked about those because I think that for the most part those were related to learning curves and technology issues that have for the most part been solved. So what I wanted to focus on today was just what objectively appears to be going on when you look at a large number of patients, okay, who have had surgery by experienced surgeons with the modern equipment that's available. Well, all of the Flax has been modern, but the most, recent. Still, despite everything that I've said today, Flax is very much in its infancy. Okay? And there's a very, very good possibility that with tweaks to the technology, perhaps the hardware, perhaps the software, perhaps changes in the way we treat patients pharmacologically, so either with drops or injections before or during surgery, that it may be possible, we may be able to reduce or even eliminate the rise in inflammatory mediators, and with that, the added risks of Flax, so that Flax could potentially not only be equivalent to ultrasound-only phacoemulsification, but better than. Okay. So to summarize, at the moment, Flax is not all it's touted to be, not by any objective criteria. At the moment, there is no strong evidence that Flax is superior to conventional phacoemulsification and may actually be a step back, at least with regard to intraocular inflammation and its associated risks and complications. But I do think that there's the real possibility that with advances in technology, that it may have the potential to make good on at least some of its promises. That's just not the case yet. And my argument is that until that's the case, it's very, very difficult for me as a surgeon to justify strongly recommending Flax to my patients over traditional phacoemulsification only surgery. Okay. Because I don't think that the coolness factor and that the bragging rights really justifies the risks that I just went over. So anyway, that's my view. You will definitely hear alternative views, but I want to thank you for attending this. And now it's off to lunch and any questions that anyone has. All right, thank you.